conflict. So we're not talking to them about conflict, and sometimes it's because we might feel angry or agitated with them. So we have to be aware, how I'm feeling towards the patient, maybe enabling them to continue this maladaptive behavior that I'm having a response to, which requires my addressing. So here's some recommendations. Always assess for suicide when risk is evident. That's just always. We always want to do that because we always want to make sure that safety is priority number one over everything else. And be mindful of boundaries with time, right? So we're the role models. So if we arrive late, we're communicating to them that it's okay to arrive late. If we go over session when they're distressed, we're actually reinforcing that when you're in distress, I'm going to give you more time. And we don't want to do that, right? I've been guilty of that. So we want to make sure we're mindful of boundaries with time. Seek consultation for countertransference. Again, if you feel angry or you have a sexual attraction or you're just really, really stuck with a patient, there is no shame in asking for help. I know at the hospital, we consult all the time with each other because it's so important. We need to know, and someone else might think of something I would have never thought of, and that's okay. I'm not meant to know everything. Thank God. We want to pay attention to the outcome of our intervention. So this is what I was talking about earlier, is you don't want to fit the patient to your case conceptualization. You want to fit your conceptualization to the patient. This is a human being, and then readjust as necessary. So let's say I felt like I knew what they needed. I knew in the moment was going to be effective, and it didn't work. Okay, try something different, right? We can be flexible in our approach. That's why we have so many different skills. And then utilize an accurate case conceptualization to understand the function. Again, this is so important. We keep saying it. What is the function of their behavior so we know how to intervene effectively? And recognize those patterns of behaviors. That's super important. What is this pattern that keeps coming up? Because this maladaptive pattern is what's getting in the way of their life and their functioning. And being able to address that in the moment, the immediacy, and addressing the process versus the content that we already talked about. And so if you notice that you're stuck with a patient, these are just some questions to ask yourself. And these are more enabling questions, right? Just things to think about. If the patient's stuck repeatedly, how might I be contributing to this problem? Doesn't mean you're a bad therapist. It just means maybe how am I getting stuck? Am I solving their problems? Am I jumping in to rescue them? Am I allowing them to push me away? Right? I can't tell you how many times, especially in DBT, I have patients come up and they'll say, yeah, when I get pissed, I just cut people off. And I'm like, oh, good. So let's predict you're going to get pissed at me and you're going to want to cut me off, right? How about we talk about that now? Let's create a strategy so that when you get pissed, and sure enough, in treatment, they get pissed, they want to quit therapy. That is a point of immediacy. Instead of just letting them quit therapy, we want to be able to work through that issue because that's their problem. Well, one of, right? So we want to be able to address that. Are they people-pleasing me? Sometimes patients are going to come in on time and they have their homework and they're doing really well and everything looks great, and then they go home and they're falling apart. And then they end up inpatient. You had no idea. Well, because maybe they're just trying to impress you. So really being able to know that behavior and the function of that behavior. And that kind of goes along with, are they idealizing or devaluing me? So am I the good therapist? And if so, what does that mean? Are they fully telling me the full story? Or am I the bad therapist and they're trying to quit on me or criticize me? And how can I help them deal with that anger differently? Okay, so those are the recommendations, and that's it.
Any questions?
Why don't we hold up the case? Thank you. Why don't we hold off on the questions? Dr. Salvatore's going to work with Dr. Wong.
Oh, it's going to be Colin.